It's fine to talk about the things that you might consider, but sometimes we want to know what you're actually going to do. In this case, it makes sense to start by identifying the urgency of the situation. And for acute hypoxemia, this can be an urgent to emergent situation depending on how your initial management goes. So you want to get help. Example, nurse or RT, someone who can help you find additional airway equipment if necessary, or different O2 delivery devices. And if you're on the ward versus in the post-anesthetic care unit, the type of help you have is significantly different. So keep your settings in mind. Then in these situations, you should say to yourself, O2 IV monitors, which always form the initial management. You want a fresh set of vitals to help inform you about next steps. Other things that can almost universally help with hypoxemia are sitting the patient upright, which helps with your pulmonary mechanics. Unless they're found to be hypotensive with your initial set of vitals, then you might find that you're worsening the situation when you elevate their brain. Insertion of an oropharyngeal airway or nasopharyngeal airway can help in a lot of cases if they're tolerated, and be ready for bag mask ventilation. With an ambu bag, you can deliver 100% oxygen with positive pressure at the patient's bedside, and that may be necessary depending on how your initial interventions go. Your goal here is essentially to establish adequate ventilation, meaning removal of CO2 and oxygenation, to give you time to further assess the patient and determine if there's a need for escalating care, like CPAP or a definitive airway. So assuming the patient is stable here, your assessment should include a focused history. You want to know something about the patient, particularly if there's any history of cardio or resp disease, OSA or something like that that could explain why they're in respiratory distress, something about the procedure that they had done. Perhaps there's something in here that could explain why they're having difficulty breathing. Was it a laparoscopic surgery? Something about the positioning. If it's incredibly painful to take a breath and they're splinting. And you want to know about the anesthesia or the meds they received. So this could explain excessive sedation or paralysis. So you should know all of this if it's a case you've done, or if you respond to a call in PACU. The PACU nurses are very good at giving you this kind of information. You want to quickly inspect the patient, and realistically you're doing this as everything else is unfolding. So you want to know about their level of consciousness and their breathing pattern. You may see something like this where their abdomen is being sucked in and their chest is rocking out. So this is paradoxical breathing or abdominal breathing, which is typically associated with airway obstruction, which happens with both sedation and paralysis. Your physical exam should include auscultation of the lungs, just listening for equal air entry, or if they're particularly wheezy or something like that. And then strength. And if you ask a patient to grip your hands, it's reassuring if they can follow that command enough to squeeze their fingers together and hold you tightly. That tells you something about their level of consciousness and also that they have some amount of strength. Then you can order investigations to further delineate. Getting an ABG and looking at the PA CO2 will tell you something about how well they're ventilating. I was going to say you can use the alveolar gas equation to calculate if you have a high or a normal gradient for your alveolar to arterial oxygen. But I guess if we're talking about acute hypoxemia, this patient is not necessarily at steady state, which means this may not necessarily be valid. In any case, if you were to do an ABG and you find that your PA CO2 is 70 when it should be 40, you know that this patient is hypoventilating. You can also order a portable chest x-ray And actually, looking at your differential, these are basically the two highest yield investigations. Just keep in mind that radiographic pulmonary edema can lag behind the onset of clinically apparent pulmonary edema. Then we have to use what we've learned from our assessment to come up with some kind of reasonable intervention for the patient. So maybe we find that they have residual paralysis, and our plan is going to be to reverse their paralysis. So if we have Sugamadex, we could use that, although currently we don't have that in our hospitals. If they are thought to have excessive sedation from opioids, you could give naloxone, the opioid antagonist. Dosing for this is 40 to 400 mics IV. The vials come in this 400 mic size, or 0.4 milligrams. If you were to give this entire vial, you will certainly reverse the opioid-induced hypoventilation, but you'll also probably eliminate your opioid analgesia as well. So if you are adequately supporting the patient, you could start by giving smaller doses. So start by giving 40 and then maybe another 40 to titrate them to a reasonable respiratory rate while still maintaining the analgesic effects of your opioid. If they have some other issue that is not immediately reversible or responding to initial management, you could escalate to BiPAP and then plan for also possible reintubation. That's about it for hypoxemia. Make sure that you know this 5-pronged differential diagnosis for hypoxemia and you have an organized approach to the patient who is hypoxemic. I just want to go over O2 delivery because we said O2 IV monitors as your initial management, but most of the time the patient will already be on some type of oxygen. So let's just look at what you might be able to do to actually improve their oxygen delivery depending on what they already have.